So our next speakers is, we're going to have two speakers joining us from Baltimore, I suppose, this morning. There's Associate Professor Jamie Shores and Associate Professor Sami Tuffaha. They're both at Johns Hopkins University. Do we have them connected? Great, I can see their screen now.
All right, hello, can you hear me? Can you see me?
Hi, Doctor. Yes, we can hear you. Please go ahead.
All right, well, thank you for this very kind invitation. It's an honor to be on this panel with really the pioneers of this exciting new field. And so what I'm going to try to do is try to take a step back. You've heard all the information now. I'm going to try to synthesize all this and kind of put it into a framework. And then Jamie Shores is going to follow me and talk about his clinical algorithm. And I'm going to try to take more of a reductionist standpoint and just basically tell you a lot of what you already heard in kind of a synthesized format. All right, so, when we talk about the contemporary surgical approaches, it's really TMR and RPNI. And you're looking at the two people who really pioneered this field, Dr. Kuiken, Dr. Doumanian, Dr. Sederna. And so, they deserve all the credit for creating all this excitement and attention. And, in the last 10 years, it's incredible to see how popular and how excited people have gotten about these approaches. And it seems like it's growing exponentially. I'll also touch briefly on a new modification that we're working on that's essentially a modified RPNI. And I think it's good to talk about this approach because it helps, kind of frame some of the concepts. So I agree with Dr. Kuiken's point that really all of this falls under the umbrella of a single concept, which is trying to prevent neuroma formation by directing the axons that are regenerating from the injured nerve that would otherwise form a neuroma into muscle such that they will reinnervate that muscle rather than form a neuroma. And the differences in the surgical approaches can be boiled down to how do you achieve that goal. And one of the things that you've heard about already is that we've all kind of decided that we need to use denervated muscle in order to achieve this goal. And so why do we think it's important to use denervated muscle instead of muscle that's already innervated? Dr. Sederna showed that seminal study by Dr. Dellon and Dr. McKinnon. The old approach, or I guess the more standard approach until these new approaches emerged, was to take the injured nerve and just bury it into muscle that's already innervated. We know that if you do that, you're just going to form a neuroma within that muscle. And the reason is that all those receptors, those motor end plates that you see down in that histology in red, those are already occupied. So they're not going to be receptive to new reinnervation. But if you denervate that muscle, now you're going to have a bunch of empty red motor end plates such that when you bury a nerve into that muscle, all those axons are going to regenerate and find those empty receptive motor end plates. And there's a whole body of work looking at this under the paradigm of direct motor neurotization, which has been used effectively for functional recovery. You can imagine you have an injured nerve. For whatever reason, you can't get a nerve-to-nerve coaptation. So, it's been shown that you can just bury the nerve into the muscle and the muscle will actually begin functioning. And this all comes down to motor neurotization. Now, there is a big leap being made here, though. We're extrapolating from this, and then we're saying that you can, the same is true for sensory neurotization of muscle. And so we are working under the assumption that sensory axons will regenerate into this muscle that's denervated and find receptors and achieve this goal of painful neuroma prevention. And I'll touch on this a little bit later. So, if you take a step back and you think about what are some of the fundamental differences between TMR and RPNI, from this kind of reductionist standpoint, TMR is using a nerve coaptation, whereas RPNI is using direct neurotization. Direct neurotization is when you bury the cut proximal nerve end directly into the denervated muscle. And there's another important difference, which is that TMR uses muscle that's already vascularized, whereas RPNIs use muscle grafts, which again do work, but they require a different type of healing and a different type of incorporation to the body. So, when you talk about the different modes of neurotization, the nerve-nerve coaptation used in TMR, there's no question that it's a more efficient way to distribute those axons throughout a muscle. They have kind of a highway that they can travel on. The nerve that you can see macroscopically keeps branching and branching within the muscle. And then there are these terminal Schwann cells that will continue to guide the regenerating axons along these nerve tracks. So you can imagine these axons more efficiently spreading throughout the muscle, whereas when you use direct neurotization, you're kind of introducing a bolus of axons, and they're much more concentrated at the site that you bury the nerve. One of the downsides to this nerve-nerve coaptation, which is just a practical consequence of the fact that we're taking a large nerve usually and connecting it to a very small motor nerve, is that you do have a size mismatch typically, and this size mismatch can be on the order of 5-to-1 or larger. And so, we do know that a neuroma will form on the end at a coaptation site that's size mismatched. And there have been some creative ways of getting around this, which make a lot of sense, which is essentially to combine the nerve-nerve coaptation with direct neurotization. And so I think TMR, which is clearly effective, there's a very high level 1 evidence showing that this works for neuroma pain. I think the way that it probably works is that many of these axons are kind of taking a beeline around that distal nerve stump and just going right into the muscle, which is direct neurotization. TMR also has some anatomic limitations. There are only so many motor nerves that you can find, and they're not always in the perfect proximity that you would hope for. So sometimes you have to make additional incisions. But again, it's a great approach. It's really the first approach that introduced this concept. And everything after that has really kind of trickled down from this. So, direct neurotization, I think using the RPNI is great because I think it's extremely practical. For the reasons that Dr. Sederna mentioned. And, I don't know what the downsides are for neuroma prevention, honestly, from a scientific standpoint. It may be that, when you have direct neurotization, you may have some kind of orphaned axons that aren't finding these receptors, so to speak, but we don't know. This is one of the questions we need to look at. So now, talking about muscle vascularity, so Dr. Sederna discussed how the muscle grafts that are RPNIs work, and they do work. We've done work in our lab that's confirmed what Dr. Sederna has shown, but they do require revascularization from a wound bed. And, that requires certain conditions. One of the conditions is that the muscle graft has to be small enough such that it can first survive by diffusion of nutrients. And so you can imagine if it's too big, then the nutrients aren't going to be able to diffuse into the central portion of the muscle in time. So you're going to get necrosis. Now, if it's small enough, it does work. We've shown this in our lab, and clearly Dr. Sederna has a whole body of work showing that this works. And you saw the end result, which is incredible. But, there is some fibrosis and resorption within the tissue. You will find many viable cells, but, throughout this process, you will have some partial loss of viability. Whereas in TMR, you're using vascularized muscle, so this isn't an issue. So, we were kind of thinking about this in the same way that I'm presenting to you. And so we created this kind of minor modification of the RPNI, which is essentially to to make use of all of these vascular leashes that you find throughout the extremities. Any of the major blood vessels, if you follow them, you'll find little branches going into muscle, and you really can't miss them. They're everywhere you look. And then you can carve a piece of muscle on this vascular leash such that it is no longer innervated. All it's attached to is a blood vessel. So you can imagine it's an RPNI on a blood vessel is what you're looking at right there. And you can cut the neuroma off then, and then you can bury the proximal nerve stump into this, we call it vascularized denervated muscle targets because it perfectly encapsulates the critical qualities which I've been talking about. But you could also call it a vascularized RPNI just as well because that's what it is. So you can see here one of the kind of technical points. Jamie's going to talk about the technical aspects of all this and how to apply this, but I just want to point out that sometimes with these big blood vessels, you will have nerves that travel with them. And so I would say at least 20% of the time when I stimulate the vessel, the muscle will twitch, and then I'll put on my 3-5 loops and I'll go digging around and find a little nerve branch and go and cut that. So, I think VDMTs are not going to be as readily available as RPNI, clearly, because you can put an RPNI anywhere because you can just take it and put it somewhere. But they are more readily available than you may think. So next time you're operating in a limb, just kind of take a look, and I think you'll be surprised by how many of these blood vessels you find. But they are not everywhere. And so if you're in the hand, in the face, especially because there's small nerves there, I think that's ideal for a VDMT, and that's what I would do. But James is going to talk about that, so I don't want to steal his thunder. You can use larger size VDMTs. And so, you saw that what Dr. Sederna does is he takes the sag nerve and he breaks it down into individual fascicles and then puts small VDMTs on it. Very valid. But you can also just carve off a big piece of muscle in about 15 minutes and put the whole sciatic nerve into there. But everything I'm saying, you have to keep in mind that we don't know how much muscle you need to treat a given sized nerve, right? For, let's say, X number of axons, 10,000 axons, what mass of muscle do you need? I don't know. I would love if somebody else knows, but that's one of these fundamental questions we need to answer. And I think this is really important, which is to say that, I don't think we really understand the most fundamental question, which is how does this prevent painful neuroma formation? We know that denervated muscle will accept innervating muscle or regenerating muscle axons, and then these regenerating muscle axons will then become quiescent and they will stop regenerating when they find their motor end plate. It's very easy to wrap your head around this. But what about sensory axons, and more specifically, what about pain fibers? Pain fibers are these small unmyelinated fibers that don't have receptors. And so what are they innervating in the muscle, or, and what's telling these pain fibers that are regenerating into the muscle to stop regenerating? And, so we're working on this. It's very hard to even frame these questions and understand what are your outcome measures going to be. You can see here, this is one of the stains we're using with SCG10, which is a marker for regenerating axons, and then substance P, which is expressed by pain fibers. We're going to the DRGs and looking at electrophysiology, spontaneous ectopic firing, looking at RNA expression and things like that. Hopefully, maybe in a few months, I'll start to have some answers for you. We're working through the final stages of a big study. I don't want to say anything presumptuous at this point, but but these are some of the questions I think it's important to, clearly they're working, right? We're doing them, we're surgeons, and sometimes surgeons get ahead of ourselves and we find something that works and we start to do it, but it still would be nice to really kind of understand some of these fundamental questions. What about the pain in the distal denervated area or the phantom limb pain? I agree with everything that Paul said. I think if you do these surgeries preemptively, prophylactically, you're going to have a better response when it comes to this more centralized pain phenomenon. I think when I counsel my patients, I tell them I can pretty consistently offer you a resolution or prevention of that very severe localized pain right at the neuroma itself. But when it comes to the phantom limb pain, many of my patients will still have some degree of phantom limb pain, particularly if they've already had it before. I think it's helping, but that's where big randomized studies are going to be needed in addition to what we already have. I think we need comparative studies, clinical studies to try to really start to work through the algorithm. Anyways, I'm going to go over. I can ramble about this for forever, but I want to hand this over to Dr. Shores. Thank you.
Okay, hopefully you guys can hear me and see my screen.
Yes, we can hear you.
Perfect. Thanks, Sammy. He's touched on just about all the big points that I think I wanted to. And Max, thanks for the invitation. It's great to be on a panel with the folks that have invented the technology we're talking about, and Dr. Kuiken and Dr. Sederna. And thank you guys for giving those talks to kind of distill everything down that Sammy and I are talking about. Also, I wanted to point out, Sammy, big champ for giving this talk. He was up till 3 a.m. last night doing a free flat because somebody snuck a quote unquote quick case into his room before he did his case. So thanks, Sammy, for doing that. I know you're exhausted. These are my disclosures. I'll add in there that I have great partners like Sammy Tuffaha and Jonathan Forsberg, and great collaborators like Max and Ricard Brannemark, which have helped us do a lot of the things we're doing. So I'll start by saying this is, kind of the Shores philosophy of nerve management, which sounds eerily similar to everything you've heard everybody else say. So I think that all of us are making the same opinions based on what we're seeing, which is good. And mine is that nerves are like teenagers. You need to give them something to do or they're going to cause trouble. And I guess there we go. The little slides just don't want to work. So we want to give them a job to do. And I think Paul's already said that, and I absolutely believe that. How do we make sense of what we should be using those? Well, I think we have to admit, like Sammy's already pointed out, that there's limited data to guide us right now. We have to admit that we don't have long-term studies demonstrating a higher level of superiority of one method over another method, though some techniques have more research already completed than others. For example, TMR has a lot of years of research thanks to Dr. Kuiken and his lab. That being said, Dr. Sederna already said this out loud. When there are multiple ways to treat the same problem, that means that either nothing works great, or it means that everything works fantastic and just doing anything helps. And in this case, I think we're going to find that all of these things are helpful, but nothing works 100% of the time, taking away all of the pain we wish it would. Just like Sammy's pointed out, there's a lot of science you still have to work out. So each technique has its own advantages and disadvantages. It may change as technology changes over time, especially when we're talking about signal amplification and how we can detect that for motor control. And when we start talking about afferent signal nerve interfaces, trying to supply an afferent signal back to nerves. And then I think we have to admit that opinions are like anuses. Almost everybody has one. So bear in mind that, there's a lot more opinion than science when you hear folks like me talk about this. These are 3 papers. I'm just going to point out because they are the folks who've invented this technology, Dr. Kuiken, Dr. Sederna, and Dr. Tuffaha for the VDMT technique we're going to talk about. So I'm sorry, that picture was supposed to come up a little bit delayed, but I was going to start off with the targeted muscle reinnervation, which is essentially a nerve transfer. Right? This is originally performed by motor control, as Dr. Damanian and Dr. Kuiken did. Dr. Kuiken was nice enough to come to Hopkins and help us do our first TMR about 10 years ago, I think now. Most current myoelectric prostheses only have about 3 to 4 inputs if you're talking about, say, a transhumeral prosthesis that has elbow and hand function. These, in their sockets, usually only have 3 to 4 inputs built into them. These are transcutaneous EMG signals. And so TMR was created for motor control originally, where they could generate big signals. They could amplify the electric signal of that nerve and the signal would be large enough that a transcutaneous EMG pad could pick it up. And it's worked pretty well for that. We can improve the function of these using advanced pattern recognition algorithms, which not everybody has. I also think that these are likely to work better in hostile wound beds. So these are big vascularized muscles. Guess what we put in hostile wound beds to try to get them to heal frequently? Big vascularized muscles. And so these work well. So what's a hostile wound bed, for example? Like a radiated sarcoma bed, or maybe an infected wound bed that you're trying to get cleared out, or that you just recently got source control of. These are usually significantly mismatched, like Dr. Kuiken said, the size of a pencil to the size of a pencil lead. And so there is potentially a lot of axon escaping. That can form neuroma. That can, in fact, all of these will have neuromas. Anybody who says that there's not going to be a neuroma at a place where they've joined these two nerves together is kidding themselves. The question is that neuroma causing pain or not? And so I think, like Sammy says, I think that there is a lot of axon escape. I think they do find other things. And so one of the ways that I do TMR to try to help with this is what the picture I'm showing here. After I do that neuroraphy, I will then try to take that denervated muscle and sew it all around that coaptation site so that as axon escape occurs, it can get into those denervated muscle fibers. So now we have some VDMT as well. I also, just about 2 weeks ago, I did an amputation on an arm. Because of the nerve branching and stuff, I couldn't do the neuroraphy right next to the muscle and embed it in like I usually like to do. And so I put a big, what I would call an RPNI. Dr. Soderna may make a grimacing face as I say that, bastardizing his work, but around that neuroraphy site as well. So you've got two of those constructs in one. I think that sewing denervated muscle around TMRs can help axon escape, is just like sewing RPNI around it can. I don't have proof for that, but this is just kind of things that we're trying out. And as Todd already said, surgeons never like to do the same thing twice. So we're always trying to improve things if we can. When we talk about RPNI, this is a graphic from one of Paul's papers. There's an enormous amount of material easily available for use, right? So as long as they've got muscle, they've potentially got source for RPNI. So that's a huge advantage for it. It can be used in most places, assuming the wound bed is not hostile, and this can survive based off of inhibition, inosculation, revascularization. And if you're going to use this for motor control, as Paul has demonstrated, it requires a more specialized signal detection interface than most, I think, of our currently available myoelectric prosthetics are capable of supporting with the standard EMG electrodes. I think as we get better with signal detection using implantable wires, which we can talk about using ultrasound-based technologies and things, that these may become incredibly useful for providing really fine motor function. And then we've got the vascularized denervated muscle targets. And these have way more sites available than TMR because they don't require finding a motor nerve branch, but obviously less than RPNI. And these could tolerate theoretically hostile wound environments better than an RPNI, because they're more similar to TMR in that they have a blood supply. They allow large nerves to be broken down into smaller components, but you could also take a large nerve and put it into a larger muscle flap that's been denervated. And you can take small VDMTs that require, again, more specialized signal detection and interface methods like an RPNI would. And so a TMR for motor control still may be more useful than this, unless it's a very large VDMT. But again, as technology improves and we are able to harness the power of smaller and smaller signals, these may become more and more useful again for motor control. So putting it all together, large expendable muscles with easy to find motor branches that are in the surgical field or in places where we want to make incisions that aren't going to compromise what we're doing, to me, favor doing TMR. And when I do that TMR, I'm going to perform TMR with muscle wrapped around that neuroraphy somehow if I can. So that's going to be like a mini VDMT or another RPNI around it to try to help prevent axon escape. If you've got a large muscle that you're going to be doing TMR to, recognize that the rest of that muscle is still denervated. If you've got another nerve nearby, you can directly implant that nerve into that muscle, direct neurotization. So that's a large VDMT. So you can do both of these at the same time. You can do them in the same muscle as long as they're far apart, so that if you're going to have signal collected from that your device can recognize those as two separate signals. For small muscles of which some are expendable and some aren't, say in the forearm, you may want to do a combination of nerve transfers, which can be, we'll call TMR, and VDMTs and RPNIs, depending on what you find and how many nerve branches are available, and what functions you want to preserve and add. Say, and a perfect example is like using the pronator quadratus in a planed amputation can be super helpful. You can do a TMR to that. You could also do a VDMT to that. And when you're doing these planed amputations, you usually have lots of available skeletal muscle that you can turn into RPNIs. And so how about small muscles that are not expendable? It should be expendable, sorry. And so that's places like the face, where you're clearly not going to take a muscle out of the face that somebody needs for facial animation to do something crazy to, or in the hand where you just don't have much expendable muscle as well. Well, the goal here in these situations is mostly pain control. It's not usually to power a prosthesis. And so I think an RPNI is likely the best treatment for that, because you can take muscle grafts from anywhere else out of the field if you want, without sacrificing any of the limited muscle present within the field. And then for smaller sensory-only nerve neuromas, if you're just trying to get pain control anywhere in the body, I think RPNIs and VDMTs both are terrific for this. And so here's an example of a neuroma and an antecubital fossa of a sensory nerve driving this person crazy for years and years. Take that neuroma off, do a little RPNI to it, and you can tell by the look on her face, she's very happy. So using them, as the kids say, IRL, right, in real life. So I'm going to give you an example. Upper extremity amputation with expected myoelectric prosthesis use, with or without osseointegration. Ours is with osseointegration, the example I'll give you. So I'm going to use TMR for the median nerve. I'm going to do TMR for the ulnar nerve if the brachialis is available, just the way Greg and Todd taught us how to do this, right? And TMR for the radial nerve if I can find a good triceps branch that's available. I'm going to do VDMT for the ulnar nerve, meaning implant that into a large vascularized piece of muscle. And for the radial nerve, if I can't find a good TMR branch, I'm just going to plug that into a denervated but sizable piece of vascularized triceps for the radial nerve if I can't find TMR branches to those things. I'm going to do VDMT or RPNI for the sensory nerves, the MBC, the MABC, the LABC. And if there's not enough muscle present, well, you can do RPNIs for these, absolutely. Or you can bring in a combination of you can bring in new muscle so that you can create TMR, VDMT, and or RPNI. But using a conventionally created myoelectric prosthesis, I'm going to favor doing the VDMT and the TMR over both of those, because I think that's going to give me the best signal generation. So here's an example of how we do that. Inadequate number of motor sites for TMR in a very short transhumeral amputation stump. What I've tapped out here are Tinel's signs on their transected nerve stumps. So I'm going to keep the short head of the biceps, which this patient has a little bit of, already innervated by the musculocutaneous nerve, so there's elbow flexion. I'm going to do direct neurotization of vascularized and denervated piece of triceps with the radial nerve. I'm going to bring up a free gracilis and I'm going to use the motor branch of the gracilis for a TMR to the median nerve. And again, I'm going to wrap that gracilis that's been denervated around that neuropathy. So I try to help capture some of that axon escape, which I expect. And then further down the line, I'm just going to plug the ulnar nerve directly into the denervated gracilis muscle at the other end of it and do a VDMT to it. And then I'm going to start burying my sensory nerves, my MBC, MABC, LABC, in denervated vascularized muscle or free muscle grafts using RPNI, in this case, RPNIs. And so here are my neuromas that I'm going after treating. I hope you guys all write on your nerves, your neuromas like I do. It's classy. And then here's the free flap that I brought up with a skin paddle on it. The plastic surgeons will recognize that, and they'll say, well, you've got to get rid of that skin paddle before you do osseointegration. Say, I know. I'll get to it. Just give me a second. Okay. So here's the skin paddle exercise. Here's our osseointegration performed. Thanks, Jonathan Forsberg. This is a compress device. And then here's this patient. First time he's using his myoelectric prosthesis after getting it. And these are transcutaneous electrodes. And he's saying hello the only way he knows how to because he's from New York. Very happy with it. So what are future developments? Well, signal amplification advances. I think it'll be possible to provide afferent stimulation that's useful and we can also use RPNIs and small VDMTs and things for signal amplification on a more reliable basis than we have with just the regular transcutaneous things. And so here's an example of that. This is a patient who had a shoulder disarticulation, horrible, and also centralized chronic pain. Median nerve, ulnar nerve, both had big silk ligatures around them. Cut those off, did TMRs, pieces of muscle that he still has there. I did some RPNIs. Paul, you'll be interested to know, I dug out one of the RPNIs when we came back to do this stage, and I stimulated that nerve, and I could see this tiniest little quiver of that muscle, which surprised me. It didn't really look like muscle anymore. Looked like almost like a neuroma kind of around the nerve, but it would quiver when I would stimulate it, which is super interesting. At any rate, I stimulate these nerves, I find where the muscles are contracting, and I'll put these bipolar electrodes in that Max brought me and that Ricard Brannemark brought me, and Jonathan Forsberg, who designed this custom total shoulder replacement device. And then we put Ricard's E-OPRA device into that in a separate third stage that goes into that device. And then we hook the wires up and we run them through there. And Max and Ricard both came for that as well, which we greatly appreciate. And this is that patient just a month ago or so. I can't remember how long this was. It's not been very long. The folks from the Applied Physics Lab at Johns Hopkins came and hooked up his E-OPRA device. And this is him starting to use for the first time, the avatar-based virtual rehab thing. And so he's figuring out how to use the elbow here and how to use the hand here. He still has a lot of centralized, horrible chronic pain, but we're hoping that as he can start to use these, and he'll develop some cognitive and behavioral mechanisms to start reusing those nerve pathways that are just doing nothing but causing pain right now, make them more useful to him. So I'm going to stop right there because I'm sure we've gone way over with all of our talks, and I want to say thank you to everybody for letting me speak and having us and having a meeting about this really hard problem that we all have a lot of interest in. Thanks a lot.
Thank you. Thank you, Jamie. We had some applauses, but I'm not sure you hear that. So we're going to have a panel discussion now. So I think there was one question, but I think that question is very good for the panel discussion. So we can set that up now if the speakers that are here want to join me in the stage.